Dr. Veena Balaji will be discussing on the systematic diagnostic approach of infective keratitis. She did her post-graduation from the prestigious All India Institute of Ophthalmic Sciences and did her cornea fellowship from there. Currently working as a consultant in cornea and refractive surgery at Chaitanya Eye Hospital, Trivandrum. Next topic will be by Nimmi Raj. She will take you through algorithmic approach of clinical diagnosis of non-infective keratitis or immune keratitis. She also did her MD ophthalmology from AIMS Delhi and subsequently did her fellowship in cornea and refractive and cataract surgery from AIMS Delhi. Currently working as a consultant cataract, cornea and refractive surgery services at Precise Eye Hospital, Trivandrum. Next, atypical keratitis and emerging corneal infection, which was to be taken by Dr. Sanjeev Srinivas. He had to leave because of some family emergency, so we'll be dropping that topic. Next, I'm myself, Dr. Sharath. I'll be taking you through the surgical strategies in case of keratitis. Last topic will be done by Ruchika Patnaik, but she's not available today. In place of her, Dr. Rashmi Kalatil will be presenting. So she will discuss on the recent advances as well as the AI in diagnostic tools in keratitis as well as management in the most modern era. So she also did her MD from AIMS Delhi and subsequently she did her fellowship from LVPI in cornea and refractive surgery services. Currently working in Ahilya Eye Hospital, Kollam. So I'll invite the first speaker, Veena Balaji, to take on the stage.
Good morning, one and all. Myself, Dr. Veena, cornea and refractive consultant at Chaitanya Eye Hospital Research Institute. Thank you, Dr. Sharath sir and KSOS for this opportunity. So, infectious keratitis has been labeled as a silent epidemic in developing countries, especially in the tropical latitudes, with an incidence as high as 113 in 1 lakh population, and its prevalence is rising every year. Recently, a consortium-led proposal suggested the designation of infective keratitis as a neglected topical disease among the other diseases like trachoma, onchocerciasis, and leprosy. Fungus is the predominant etiology, which comprises more than 50%, with Fusarium and Aspergillus accounting for more than 2/3 of the isolates. So risk factors from this study done by Chidambaram GD et al. In South India were mean age of about 50 years with male predominance, especially agricultural workers with lack of formal education. Preceding trauma was seen in 72% of the cases, with most common mode being vegetative matter. Ocular risk factors like blocked duct were seen, which led to pneumococcal bacterial keratitis. Diabetics were prone to fungal more than bacterial keratitis. So while approaching a case of keratitis, history takes a major role. You have to ask for history regarding recent use of contact lens, in especially cases where you're thinking in terms of pseudomonal or acanthamoeba keratitis, and trauma with vegetative matter in fungal keratitis, and exposure to any contaminated water sources, which should ring a bell regarding acanthamoeba or microsporidial keratitis. In recent history of any ocular surgeries, for that matter, it could be refractive surgeries or C3R. So clinical examination, visual acuity, intraocular pressures. Detailed adnexal examination should be done, including ducts and lid margins. And ocular surface evaluation of the fellow eye is very important to rule out any dry eye disease. Detailed corneal examination under slit lamp. In all cases of keratitis, you have to document the size of epithelial defect and infiltrates, and degree of stromal edema and DM folds, AC reaction, especially hypopion. You have to measure the level of hypopion, whether it's fixed or mobile, corneal vascularization, and if any associated scleritis is there, that should be documented. So clinical cues to a specific diagnosis, fungal keratitis, usually they are very fluffy with feathery margins, with presence of satellite lesions, and you can see endoexudates on the endothelial side with a fixed hypopion. When you come to a bacterial keratitis, will be in gram-positive cocci. Usually they present with a well circumscribed ulcer with a central clearing, and you can see the adjacent stromal edema with high cellularity and a mobile hypopion. In gram-negative bacilli, the picture will be more or less same, but you should look for thinning and impending melting, especially pseudomonal keratitis. Investigation, the most important and the solemost investigation for keratitis is corneal scraping. And in cases where the patient has used contact lens recently, you can send contact lens cases and solutions as well for microbiological evaluation. And microscopic examination, grams and KOH is done immediately, and you will get reports within 15 minutes, which will aid you in the diagnosis and culture sensitivity as well. So when the most important question is when to scrape. When are you supposed to scrape a case of corneal ulcer? All ulcers, irrespective of their size or the time of presentation, you are supposed to scrape before starting the antimicrobials. So tailor-made approach, a case-based discussion. So this is the first case. So 67-year-old diabetic lady who presented with history of redness and whitish opacity in the right eye since 1 week. So this is how she presented to us. So when you look at this clinically, you think that is a fungal keratitis. And as usual, we started her on antifungals after taking a scrape, which unfortunately came to be negative for any fungal elements. But still we, as a clinical diagnosis was that of fungal keratitis, we put her on antifungals. But then as you can see, the next visit, the ulcer progressed with the margins becoming more fluffier and the hypopyon worsening. And to our surprise, we can see that the gram stain report showed, the culture report showed heavy growth of Aeromono species, which is gram negative. So that's when it rang a bell that it could be a mixed infection in this patient. So we put her on antimicrobials targeting gram-negative bacilli. So now you can see the ulcer started responding to the medications. The hypopyon is coming down, the ulcer is responding, it's healing. And 6 weeks later, you can see that the cornea is scarred well. So from this, the lesson learned is while diagnosing patients based on clinical signs, the probability of differentiating between fungal and bacterial is less than 70%. So you should always go ahead with a simple corneal scraping, and microbiological evaluation is the way to go always. So next case is a 23-year-old female who is an occasional CL user. You can see this is how she presented to us. We can see that there's a wreath-like pattern with pinpoint infiltrates which rang a bell of nocardia. Scraping was negative for gram stain and KOH. No fungal elements were isolated. But then you can see the next day, we started her on amikacin and antifungals. Next day, the ulcer started progressing. You can see the infiltrates going along the path of corneal nerves. That's when it rang a bell of acanthamoeba, keratoneuritis. So we did a biopsy since the scraping was negative. Unfortunately, biopsy was also negative for any acanthamoeba cyst, but due to high clinical suspicion, we put her on 0.02% PHMB, and this is how she started responding to the medications. And finally, 3 months later, we got a BCV of 6 parts. So even though there is no microbiological evidence, with sharp clinical acumen and detailed history always helps. So lesson learned number 2, even when there is no microbiological evidence, serial follow-ups and monitoring with high clinical suspicion also plays a major role. So this is a case 3, 23-year-old female who underwent PRK surgery. She came to us 2 months later with this clinical picture. You can see dry looking ulcer with kind of satellite lesions down there infronasally. We scraped her, but scraping was negative. We started her on antifungals with high clinical suspicion of fungal keratitis, but then she progressed. By then by day 3, we had got the culture report, which showed Bacillus cereus in this patient. So as soon as we started her on amikacin, the ulcer started responding. And however, in this clinical presentation, you can see that a melt has started coming in. So that's the point when we had started steroids in this patient, and subsequently she scarred well with a BCV of 6 3 weeks later. This patient, we had initially started her on cefotaxime. She didn't respond. When the resistance report had come, culture sensitivity had come, she was resistant to cefotaxime but sensitive to amikacin. As soon as we shifted her to amikacin, that's when she responded. So antibiotic resistance is often overlooked, and it's another reason for ulcer progression. So lesson learned number 3, identifying medicamentosa and managing it leads to faster ulcer healing. Timely steroid use is critical, which aids in scar modulation. So the last case, 51-year-old male diagnosed with viral keratitis in left eye elsewhere. He was using over-the-counter steroid antibiotic formulation since 3 years. So he had presented to us with this geographical ulcer. As soon as we stopped the steroids, he got another infective ulcer episode. Scrape was negative, but then we had put him on antifungals, and his hypopyon, the ulcer was worsening. But later on, he was put on antifungals as well as amikacin. All the antimicrobials were going in half an hourly and 1 hourly initially. That's why he was not responding. As soon as we tapered the antibacterials and put him on antifungals alone, that is amphotericin, he started responding to medications. And this is how he's healing now. So lesson learned number 4, polytherapy targeting multiple organisms is not the way to go. It reduces penetration of the required antimicrobial, which in turn leads to ulcer progression. So now comes the main thing, how to differentiate between infectious and sterile infiltrates. Sterile infiltrates usually peripheral with lucid intervals in between, nil to minimal overlying epithelial defects associated with vascularization. Hypopion's are very rare and it's associated with poor lid margins. Viral keratitis, various types from epithelial to geographical ulcer to stromal endothelitis, and finally the end-stage healed viral keratitis. So this is the diagnostic approach. Document the findings always. Send samples for gram stain, KOH and culture. Start empirical therapy based on stain reports or clinical suspicion, whichever is available immediately. And then if fungal hyphae is present, start the patient on antifungal therapy. Gram stain, if the organisms are isolated, and if the patient is already responding to the empirical therapy, continue the same. If not, change according to culture sensitivity. If the gram stain didn't isolate any organism and if the ulcer is less than 2 millimeters in periphery, superficial and not involving visual axis, start the patient on monotherapy, most commonly fluoroquinolones. More than 2 mm central ulcers with mid to deep stromal and involving visual axis, start the patient on combination or on fortified medications. So these are the various topical antibiotics which can be started for bacterial keratitis depending upon the gram positive or gram negative characteristics. So this is the TST protocol which is usually followed for fungal keratitis, which is targeted topical and systemic therapy given by Namada Sharma et al. Treatment protocol for herpes keratitis, which was given by Head's trial. And finally, the take-home message is, though the diagnosis of microbial keratitis is quite challenging, the art can be mastered with experience. Detailed clinical history is very crucial. Corneal scraping is to be done at all times possible. Microbiological and clinical diagnosis goes hand in hand. Beware of confounders. Cocktail treatments, steroid use, antibiotic resistance, and use of native medication should be always kept in mind. Knowing when to refer the patient to higher centers is extremely important. Thank you.